Thanks, Jim. I appreciate the introduction. So today, I thought we would go over gastroesophageal reflux disease and try to give everybody the diagnosis, management, and talk about some of the newer things and less invasive treatment options, because GERD is very, very common, something that primary care physicians are going to be dealing with quite often. And a lot of research has been done that shows that it is a very broad disease that can have multiple different symptoms. But it's a potentially lethal disease because it can lead to esophageal cancer, which even in this day and age, although we've made great strides, the 5-year survival rates are very poor. So share screen. Okay, and do I double share? Okay. Okay. All right. Which one do I push? Hang on, we're getting the slides. You can get rid of me. Okay, can I get rid of this?
We'll keep your video on there, and you're just real small, and then you just move the arrow key toward it.
Okay, so just to kind of quickly go over the pathophysiology of gastroesophageal reflux disease, initially it was thought to be simply due to transient lower esophageal sphincter relaxations. The lower esophageal sphincter would relax and reflux would come up and cause problems, but really it's a multifactorial disease that has both functional and anatomical components to it. The main part involves the esophagogastric junction. Anatomically, we get hiatal hernias, we get weakening of this junction, along with functional abnormalities where you get transient relaxations. These anatomical abnormalities, such as a hiatal hernia, as you'll see, will alter the ability of the esophagus to clear out secretions, and then also the stomach may stop functioning, and patients can have delayed gastric emptying or gastroparesis, which also can promote reflux disease. There's also a component to that we see now with some patients have hypersensitivity to the esophagus, so they feel the reflux more, and we'll talk about that subset of patients as well. That being said, there's no gold standard for diagnosis of GERD. To go through some of the anatomy, two things I want to point out that unfortunately I don't see every gastroenterologist doing this, but one important item that we want to do during EGDs is to grade the EG junction with a Hill classification. And normal is going to be the right crust of the diaphragm wrapping around the EG junction here. And if you look over to this side, that will create the angle of His there. So the diaphragm muscle will provide support to the lower esophageal sphincter. The right crust comes around and it will contract and prevent provide that angle to prevent acid reflux. If the crust becomes weakened or loose, then you're going to have Hill grade 2, and you can see this separation here. You can still see it, the crust here wrapping around the scope, but it's much looser. Hill grades 3 and 4 are going to be correlated with your hiatal hernias. You have a hiatal hernia here and loosening of the crust of the diaphragm to the point where you can actually see the esophageal mucosa in the squaminocolumnar junction. And then Hill grade 4 are usually these very large, potentially complex hiatal hernias, usually your type 2 and 3 hiatal hernias. And so this becomes extremely important because these patients are going to be the ones that are most difficult to treat with medication alone. GERD, by definition, is reflux of stomach contents into the esophagus. causing symptoms and potential serious complications. And the two big ones are esophageal strictures, Barrett's esophagus, which is a precursor for esophageal cancer. GERD's easily diagnosed on EGD if we do see inflammation of the esophagus. We don't need to do any further pH testing when we can see that there is inflammation at the end of the esophagus. And the best tested classification system is called the Los Angeles classification system, and it's got a specific definition, A, B, C, D, D being the worst, A being the least. Again, this is something that should be used by all gastroenterologists and endoscopists to grade the degree of inflammation. And again, we will see later on that patients who have moderate to severe, the Los Angeles class C and D inflammation are going to be more difficult to treat. Also, the way we diagnose reflux disease is with ambulatory pH monitoring, and that's a catheter up a patient's nose while they're awake, and they wear that around off medication for 24 to 48 hours, keeping a diary of their symptoms. They turn in the monitor and it will give us a readout of the amount of acid coming up into the esophagus, and we'll calculate a score from that. Everybody knows usually the typical symptoms of reflux disease: heartburn, substernal burning, regurgitation. Patients will say, gosh, this stuff flies up in my mouth, usually after laying down to go to sleep at night, can waken them from sleep, and it creates a very nasty taste in their mouth. Sometimes it'll cause choking or coughing. Chest pain, reflux disease, the same nerves that innervate the heart, innervate the esophagus, so they can present with chest pain. And I do want to highlight epigastric pain, not necessarily as always ulcers or gastritis or gallbladder, but it could be reflux. There are also a lot of atypical symptoms of reflux that I want to remind people about, as far as hoarseness, throat clearing, chronic cough. I feel like I have a lump in my throat or a globus sensation, and some patients may have a sore throat or laryngitis. And so, again, like I said, reflux is extremely common. About 1/3 of the population has reflux disease, and 1 out of 10 patients on average are going to have daily symptoms. So very common disease process we have to deal with. So going through the diagnosis, like I said, there's not a gold standard for diagnosis of GERD, but if you do have a patient, which you're going to have, primary care physicians are going to be the frontline providers seeing these patients. And if you have a patient who has classic reflux symptoms and they have no alarm symptoms, and I'm going to go through those alarm symptoms with you on the next slide, but if they have the classic symptoms, then there is nothing wrong with giving them an 8-week trial of proton pump inhibitor therapy. Along with that, we do want to stress lifestyle changes. If they're overweight, they need to lose weight. Avoid eating 2 to 3 hours before bedtime. Cigarettes and tobacco products are going to lead to more lower esophageal sphincter relaxation episodes. They can elevate the head of their bed at night. And there are trigger foods that they should avoid. Commonly, the trigger foods are going to be red sauce-based foods, spaghetti sauce, pizza sauce, peppermint, chocolate, not necessarily spicy foods. And then there are going to be some foods that patients that aren't going to be on the list that patients will say, that gives me reflux. This is better than jumping straight into, endoscopy or pH monitoring. Those are very invasive, and this is a good place to start. It's not 100%, it's got a low specificity, reasonable sensitivity. If a patient presents mostly with chest pain, the recommendation from colleges of gastroenterology is to exclude a cardiac cause first and then go straight to testing. Do not give these patients PPIs as an empiric trial. Of note, an esophagram is not a bad test if you're looking for patients with alarm symptoms and they're somewhat reluctant to get an endoscopy, but you cannot make the diagnosis of reflux based on an esophagram alone. So I wanted to stress the alarm symptoms. Lots of people are going to come into your office. When do you see patients who have standard reflux and reflux disease symptoms? When do you want to say, hey, wait a minute, I'm not going to put you on a medicine. I need to send you for a scope or maybe even an X-ray, esophagram. These are the ones. Obstructive symptoms, vomiting, usually more than 7 days, not in a row, but over the course of a month or so. Difficulty swallowing, painful swallowing. They've lost some weight. You've checked some labs, their hemoglobin's dropped, they've seen some blood or coffee grounds in their emesis, or they've had black stools, or they did have an esophagram or CT scan that shows some sort of obstruction, abnormality, or thickening of the esophagus. Other patients that you've seen in your office, they had the typical symptoms, no alarm symptoms. They went ahead on 8 weeks of PPI, but they didn't get complete relief of their symptoms. They should be referred for an EGD. I'm gonna jump through this slide, but I wanted to focus on, so a patient comes in and now we're down here from this last slide, we've given them a PPI for 8 weeks, typical symptoms, and they didn't really get relief. We got an EGD on them, and we ask them to stop their PPI for 10 to 14 days. If the EGD is abnormal, then we will treat them appropriately. As far as the degree of esophagitis, whether they have Barrett's, then we know we have a confirmed diagnosis of gastroesophageal reflux disease. If there's something else there, then like eosinophilic esophagitis or something along those lines, we'll treat them appropriately there. When they get a normal EGD, that does not exclude reflux disease. And I'm going to have another slide explaining that. What we would do if the patients are still having symptoms is we would consider pH testing on these patients. And I put another arrow down here, and these patients aren't nerds, but they do have a subset of reflux that's the most common, called non-erosive reflux disease. And again, research has been shown using some techniques on EGD that can help make a diagnosis without putting these patients through pH monitoring. So reflux disease, extremely common, more common where we do an EGD and we don't see any visible esophagitis on regular white light endoscopy. About 1/3 of patients will have the Los Angeles class associated esophagitis. But these patients have the same symptoms of heartburn, regurgitation, etc. But the way we're doing this now is using a special light with endoscopy called Narrowband Imaging, and this is on all of the new endoscopes that are currently being used today. It's a click of a button, and Narrowband Imaging allows us to look at the microvasculature of the esophagus, and we're looking for 3 different areas very closely. We're looking for these capillary loops, we're looking for small erosions, and we're looking for an abnormal ridge pattern. If you have all 3 of those, then you're 75% accurate of diagnosing these patients with non-erosive reflux disease. And if you don't have any of them, then you're 90% sure that they don't have reflux disease, and we might need to look at another cause of their symptoms. Could they have gastroparesis? Could they have a pulmonary issue? So on and so forth. this may be more favorable to diagnose this subset of patients because the patients are completely asleep for an EGD, as opposed to pH monitoring where they're awake and they have a catheter up their nose. So moving on to the management of reflux disease, if the going back to our initial patient that does not have any alarm symptoms, we put them on the PPI. We've talked about where we go with those who don't have great relief. Those who have good relief, then the options are to decrease the PPI to the lowest dose possible. And that can include taking it every other day. Some patients, if they've worked on those lifestyle changes that we talked about and they've lost a little bit weight, they've gotten smarter about what they're eating and their food choices, they may only need a PPI as needed, once a week, twice a week, that kind of thing, and that's certainly okay. So try to decrease to the dose of PPI. The other option, especially in the chest pain subset of reflux patients, is to switch them over to H2 receptor blocker. We're no longer using Zantac because of a carcinogen issue that came up relating the tablet to, I believe, bladder cancer, but certainly Pepcid is one that is effective. And in this subset of patients, they believe that H2 receptor blockers does something to the receptors to help with esophageal hypersensitivity and relieve the symptoms of chest pain. What we do not recommend is routine addition of medical therapy. We don't recommend using Carafate except in pregnancy. And baclofen can be used to strengthen up the lower esophageal sphincter. It does have significant side effects. Usually it makes people very drowsy and sleepy, but we want to have more objective evidence. We want to see either pH monitoring that's positive or esophagitis on EGD. And if we do that, PPI and lifestyle, about 60 to 70% of these patients are going to be, we're going to have effective results with medical therapy and lifestyle changes. If we have our patients who had, oh, I felt a little bit better, but I'm still having breakthrough reflux, and we went ahead and did an EGD, and we saw, either Barrett's esophagus, or we saw moderate to severe esophagitis from our Los Angeles classification. That's going to be the subset of patients that are going to be on a PPI indefinitely. Patients who have more severe esophagitis are more likely not to respond to PPIs, and we'll get to that. And patients with Barrett's esophagus will again get to that as well. But those patients can progress to esophageal cancer, and PPIs have been shown to decrease that from happening. With a normal EGD or only minimal esophagitis, this is where you have a little bit of controversy as far as, do you just keep them on a PPI? Are PPIs safe or not? Or do we go ahead and look further, go ahead and make sure absolutely they need that medicine or not? And that's somebody we would, want to see in the office under a GI referral and talk about possible pH monitoring. But I want to talk about for the subset of patients that have the extraesophageal symptoms, my recommendation is refer to one of the gastroenterologists. And those patients, this is a very nebulous pathophysiology that nobody has really been able to completely figure out and iron out. Even in the GI world, it's very challenging to treat these patients. And so essentially what we would do for these patients is increased high doses of PPIs for 12 weeks. And if they didn't improve, then we would send them for monitoring with pH testing. And the majority of these patients are going to have negative EGDs. So this is not the most common. I do want to mention it, but if you have these kinds of patients, you're certainly, we bump up the dose of PPIs, we bump up the duration, but these ones are difficult for any gastroenterologist to treat. So I would refer these to us. Refractory GI, these are refractory GERD. You know, studies show that it varies, but the main thing I want to point out here is that patients, down here, patients who have more advanced esophagitis are more likely to have refractory symptoms. So if you have a patient that, you know, had suboptimal response to PPI, we did an EGD, and again, we saw the moderate to severe esophagitis. Those are the ones that they're going to be a little bit more challenging to treat, and they may not get treated adequately with medications alone. I don't want to try to read my slides to you, but these are statements from the American College of Gastroenterology that came out with a position paper on the diagnosis and management of reflux disease this year. Because there has been so many studies that have come out suggesting the danger of PPI medications, some of the things that have been studied are intestinal infections and C. diff colitis. This actually is one of the biggest warnings, that if you have a patient with chronic refractory C. diff colitis, they have to be stopped. PPI must be stopped in those patients. But it's looked at pneumonia, especially in patients in the ICU on ventilators, risk of stomach cancer, osteoporosis, chronic kidney disease, vitamin and mineral deficiencies. The two big ones are iron deficiency and low magnesium, and then heart attacks and strokes because omeprazole interfered with the metabolism of antiplatelet therapy. And all of the studies had different flaws. None of them are considered definitive and do not establish a cause and effect relationship between PPIs and adverse conditions. And when I have patients that come in and say, oh, you know, my doctor, my neighbor said I shouldn't be taking this, these are dangerous, I think it comes back down to just basic medicine, that with any medicine that you prescribe, whether it's a PPI, a hypertension medicine, a cholesterol medicine, there's risks and benefits to any medications. And the same goes with PPIs. High quality studies have found that PPIs do not significantly increase the risk of any of these conditions except C. diff. Nevertheless, we cannot exclude that PPIs might confer a small increase in the risk of developing these adverse conditions. For the treatment of GERD, gastroenterologists generally agree well-established benefits of PPIs far outweigh their theoretical risks. So again, I'm not saying that they're totally safe and I want to keep patients on PPIs and blast them out of the water with them. I do not. I want to follow what the guidelines say. And the guidelines say that if they do work, we want to get them on the lowest dose possible. We might even try to switch them over to an H2 receptor blocker if feasible. But patients on PPIs, a couple of things that I think are important to know are if they don't have any risk factors for bone disease, there's no reason to put them on calcium or vitamin D supplementation or check DEXA scans earlier than they normally would for health maintenance. If they have no risk factors for kidney disease, then you don't need to monitor their creatinine levels. Those who are on clopidogrel, and they have mild to moderate esophagitis, or they're not controlled with other medications, the highest quality data suggests benefits of PPI outweigh their proposed but highly questionable cardiovascular risks. So, and we're going to talk a little bit here in a minute about the complications of GERD that we want to avoid by keeping people on these medications. And certainly patients who do have more advanced reflux disease and breakthrough symptoms, they can be treated with PPIs even if they do have chronic kidney disease with close monitoring or touching base with their nephrologist. Patients who have refractory GERD, those are going to be the ones, as I mentioned before, that you're going to refer to us. We will consider possible esophageal manometry, which is looking at the function of their esophagus, whether they have esophageal spasms, looking at the lower esophageal sphincter, seeing if it's too tight, too loose, making sure they don't have achalasia or esophagogastric junctional outlet obstruction, which is a more recent diagnosis that's achalasia-like that we're seeing a lot of in patients who are on chronic opioid medications for chronic pain conditions. We'll do pH monitoring, and in some cases we'll do what we call impedance monitoring. Impedance monitoring is a little bit different than pH. pH is just how low is the pH, how much acid is coming up in the esophagus. Impedance monitoring looks at the reflux that comes into the esophagus, whether it's acidic or basic. The pH doesn't matter. We want to know all the different reflux. So we can even do impedance monitoring on medication to get an idea of how much is coming up. And then we would most likely do an EGD. If patients have regurgitation as their primary symptom, then we would consider more aggressive, invasive options of therapy, such as endoscopic or surgery. But before we go into endoscopic or surgical management, we want to optimize their PPI therapy, making sure they're taking it on time, confirm that it is reflux with pH monitoring and or EGD or both. We want to define their anatomy. Like I told you, the Hill grade, what's their esophagogastric junction looks like, looking at a size of hiatal hernia. Again, we want to rule out other things with manometry, such as achalasia, the esophagogastric junction outlet obstruction. Talked about pH testing. And then in some patients, we may want to do a gastric emptying scan to make sure the stomach's emptying as well. Moving on to more invasive treatment for GERD. The majority of patients are going to be treated with medical and lifestyle therapy, but there are going to be some that are truly refractory that have failed PPI. They did one study, the New England Journal of Medicine, of 300 plus patients. They had heartburn, they failed PPI, but only 78 patients had truly refractory reflux related symptoms, and they divvied these patients out to receive surgery or medical treatment with baclofen and PPI, or baclofen and placebo, and the surgical patients had overwhelmingly better improvement. So surgery does have a role in reflux disease. We're not going to see a lot of this, but patients who have long segment Barrett's esophagus that we're not getting rid of endoscopically with therapy, lung transplant patients, and patients who've had therapy for achalasia. But when do we think about surgery for patients? Well, if they have a very large hiatal hernia, they have they've had objective evidence, and they've had moderate to severe esophagitis, and you have them on lifestyle, they're trying to follow their lifestyle changes and monitor their lifestyle and managing it, and they have symptoms on maximal therapy. But the problem about this Fundoplication is that it doesn't really It has a lot of immediate complications, difficulty swallowing food in up to half of the patients. Wrapping the GE junction alters the autonomic nervous system. A lot of patients develop diarrhea. Gas bloat syndrome is not only an immediate side effect or complication, but it can be long-term. And gas bloat syndrome is basically the stomach is wrapped that patients will ingest air with their meal or drink and they cannot burp. And it creates an extremely uncomfortable sensation. And as time goes on, they get recurrent reflux as this area starts to loosen with age, etc. One study showed that over half patients are back on PPIs 10 to 15 years after Nissen fundoplication. But a newer one that is on the block that has better results, less complications, is called the Watson anterior fundoplication. It's a hemifundoplication, not all the way around, and we've seen decrease in difficulty swallowing and gas bloat syndrome. Patients are symptom-free after 3 years. The majority of patients are symptom-free, and we're not seeing as high of a gas bloat syndrome. Another less invasive option surgically for reflux disease is this magnetic ring that goes around the EG junction where the lower esophageal sphincter is. This is done laparoscopically, and the purple slide, this is what you would see on a typical pH study report, as far as the percentage of time, total number of reflux episodes, etc. And from a pH report, we get the Demeester score. A group of patients had high Demeester score. The normal is 14.5, and a year after magnetic sphincter, it normalized. And this is a pretty long-lasting option in the right patients. PPI use was only 15% at 5 years, heartburn in 12%. They were dissatisfied before, but only 7% at 5 years after were dissatisfied with their lifestyle from reflux. The big challenge with the magnetic sphincter is getting the patients to follow the correct diet post-operatively. Surgeons have them on a very specific diet because, as you can imagine, if certain foods aren't eaten properly, this will develop a narrowing to the esophagus and they will develop dysphagia or difficulty swallowing. There are so endoscopic therapy for reflux, this falls into my area of expertise. And since I was training as a gastroenterology fellow, I believe there's been about 6 different devices, options to try to bolster the esophagogastric junction. And honestly, most of them have fallen out of favor. There are 2 that I will mention that can be performed. But again, the long-term 10 to 15 year data is not there. So we want to make sure that these patients have objective evidence of reflux. And these have to be very selected patients. We're not going to do this in patients who have Barrett's, severe reflux, large Heidel or Hill grade 4. Actually, it should be a Hill grade 3 or 4. And we don't want a Heidel hernia greater than 2 centimeters. So very selective group of patients we can look at for these devices. The first one is called transoral incisionless fundoplication. And the purpose of this device is to use a vacuum that pulls part of the esophageal mucosa and the gastric cardia mucosa down, and it will staple it together. And it creates an omega barrier that mimics the angle of His from the right crust of the diaphragm. Low risk of complications, about 2 to 3%, which is less than Nissen fundoplication. Really good at eliminating regurgitation, 87% at 3 years, 86% at 5 years. That's pretty good data, but the big problem here, as we'll see with a lot of endoscopic and even surgical therapies, complete cessation of PPIs. It was 71% at 3 years, but it dropped down to 46% at 5 years. And there is a redo rate with TIF, but that's usually when you're first starting out with these procedures. This was the Tempo trial that I mentioned, those results. And there was the other disturbing part about this, not only is that the improvement PPI use, but the quality of life wasn't that much improved. Less invasive than TIF is what we call anti-reflux ablation therapy. This is much simpler to do. We're again going to focus on patients who do not have large hiatal hernias, don't have Barrett's esophagus, do not have severe esophagitis. But you can see in this example, this is a Hill grade 2 EG junction. And what we're going to do through the scope is use a catheter that ignites argon gas, and we're going to burn the mucosa and the submucosa in a 270-degree angle around the lesser curvature of the stomach. When this heals up, it'll ulcerate and heal. It will scar down and create more of a Hill grade 1. So it'll tighten that area around the scope. This is fairly new. It's been out about 4 years. Success rate about 90%, 72% at 3 years, 90% at 1 year. Patients without PPIs at 1 year, about 70%. Adverse events, mostly postoperative pain or discomfort in the upper abdomen, lower chest, and 1 out of 10 patients needed to have a repeat EGD to dilate. Most of that was probably earlier on in this technique when physicians were burning too close. Now the technique is to burn in the gastric cardia away from the junction to avoid that. Lastly, we've talked a lot about reflux, why it happens, what to do when it happens, the importance of PPIs, when to maybe avoid them or when to keep using them, the safety of keeping using them, etc. And I want to talk about the complications of reflux, that this is not only common, but a very potentially dangerous disease. Esophageal strictures are one potential complications. 70–80% of patients with strictures, they're due to reflux, and it occurs in up to 1/4 of patients. Strictures, the majority of them, I'd say 8 to 9 times out of 10, we can get away with doing EGDs and dilating these. Sometimes one time, sometimes we have to do escalated dilation over a few weeks. About 1 out of 10, though, they require even more invasive endoscopic therapy with esophageal stenting, ongoing dilation, etc. So esophageal strictures are definitely a nuisance, not as deadly as Barrett's esophagus. And about 10 to 15% of patients with reflux will develop Barrett's esophagus that Dr. Barrett found in England. Barrett's esophagus is a change from the normal squamous cell esophageal mucosa to small intestinal columnar cell mucosa. What it looks like on regular white light endoscopy, dark pink versus light pink. But Barrett's esophagus it can progress in certain individuals to esophageal cancer. And I tell my patients, look, it's not going to go to esophageal cancer in a week, a month, or a year. And I can't guarantee it's going to go to esophageal cancer, but it will progress down this pathway of low-grade dysplasia or high-grade dysplasia. And pathologists, so I'll get into that in a minute and show you how we survey that and evaluate for dysplasia. But it's pretty common in the United States. 1.6% of the population has Barrett's esophagus. What increases the risk for going from Barrett's esophagus to cancer? Age. As you get older, you're more likely. Males, those who smoke. The longer the segment of Barrett's esophagus, the more likely those patients are to progress to cancer. Once we diagnose patients with high-grade and low-grade and high-grade dysplasia, they're at a higher risk than patients who just have Barrett's esophagus without dysplasia of progressing to cancer. Controversy about adding aspirin or statins that they can decrease progression. Nothing definitive is recommended by any of the colleges of gastroenterology of patients who have high-grade or low-grade dysplasia, putting them on a statin or adding an aspirin. But studies have shown that those may have a protective effect. So the risk of Barrett's esophagus going to cancer is about 0.5% per year. But once you get to low-grade or high-grade dysplasia, it can go up to 13%. Once you get to high-grade dysplasia, it's about 6% per patient year of developing esophageal cancer. Some study shows up to 30%. And again, those are probably due to the presence of those multiple risk factors: age, smoking, and the length of Barrett's esophagus. And again, I wish I could say all my colleagues in gastroenterology use this criteria, but this is the preferred criteria around the world, called the Prague Classification. And this is measuring the maximum height of Barrett's esophagus, but also the maximum that the Barrett's esophagus is involving the circumference of the esophagus. And this is something that is used prior to treatment and after treatment to see how well we're doing treating in Barrett's. This is what we don't want to see in patients on EGD or patients that we're keeping an eye on with Barrett's esophagus. And some pretty scary statistics here. 40% of patients with esophageal cancer do not have a history of GERD, and less than 10% have a history of known Barrett's esophagus. So again, so this is pretty scary that these patients don't even know. So again, if you have that patient that, over 50, overweight, smoking, they have a family history of esophageal cancer or reflux disease. They say, oh, I've never had this. Those are patients that I'm going to look at and say, well, you're getting a colonoscopy and you've got all these risk factors. And even though you don't have what you call typical reflux, we may want to do an EGD anyway. So something to think about there. So for patients, I want to emphasize this slide, that patients who need screening for Barrett's esophagus, if they have a history of reflux, on medication, and any of these other risk factors, greater than 50, obese, more likely in Caucasians, males, cigarette smoking, family history, their increased risk for Barrett's esophagus goes up 0.2% per factor. So 6 factors. So their increased risk of having it is up to 20% if they have all of these factors. So if they have GERD and these medications, we definitely will do an EGD alone. However, I've had patients that have come in for a screening colonoscopy. The nurses in the endo unit will say, this patient's 50, they smoke, and they had a history of esophageal cancer in their family. Do you want to do an EGD? And the answer is absolutely yes. Just to show you the difference, I mentioned narrowband imaging. This is what narrowband imaging is. We talked about that before, and we used that to thoroughly examine Barrett's esophagus. Before the protocol, and we still use this in large segments of Barrett's esophagus, the Seattle protocol will take biopsies, 4 quadrants, 1 centimeter if patients have dysplasia, 2 centimeters if they don't have dysplasia. Before we do random biopsies following this protocol, we use the narrowband imaging to look for any abnormalities, and we'll do target biopsies there. Patients who have Barrett's esophagus, quit smoking, weight loss, and all the lifestyle modifications. And I explained to my patients with Barrett's to take their PPIs daily. And I explained to them, even if they don't have reflux symptoms, they need to take their PPIs because that is shown to decrease progression. 44% of patients with Barrett's esophagus lack daily reflux symptoms. I'll sum up this slide. This is surveillance of patients who have Barrett's esophagus. So once we diagnose Barrett's esophagus, you're stuck with us, so to speak. If they don't have any dysplasia and we do an EGD, we see Barrett's, we're going to repeat that EGD within a year to confirm it. And then we're going to do an EGD every 3 years is my recommendation if they have any of the risk factors I mentioned. If they do not have any of those risk factors, they don't smoke, they're normal weight, they don't have a family history, and they don't have a long segment of Barrett's esophagus, then I would consider pushing them out to every 5 years. If you have low-grade dysplasia, the option is to treat the Barrett's esophagus to get rid of it. If they have high-grade dysplasia, then we're definitely treating. I'm going to move on to treatment options real quick. I know we want to save time for questions and comments. Endoscopic eradication therapy. When patients had Barrett's esophagus with high-grade dysplasia, when I was starting my training, those patients were considered for an esophagectomy because of the risk of esophageal cancer. As time has gone on, we now will do 2 different things. Well, we'll do 2 broad different things to get rid of Barrett's esophagus once they develop dysplasia. We'll either cut the Barrett's out or we will burn it out. First way, we cut out a very small lesion of Barrett's esophagus, less than 1.5 centimeters, is with EMR. This involves sucking this nodule of within the Barrett's into this cap, putting a rubber band around it, and then using a snare and guillotining it off. EMR is good for very small lesions. However, the biggest risk is that there are recurrence rates if you don't get rid of the rest of the Barrett's, number one. And if the lesion is greater than 1.5 centimeters, then you may have positive margins. So the newest one on the block that I received training for in 2017 is a more invasive, aggressive form of removing focal nodular areas of Barrett's esophagus with dysplasia or even early cancers of the esophagus. And this is called endoscopic submucosal dissection. Essentially, we mark a border around the target area. We will inject a solution that lifts that target area up, make an incision around it, and then guide the scope and a knife underneath it into the wall of the esophagus to lift this and dissect it off in one piece. This is good for lesions greater than 1.5 centimeters. Lesions that are extremely flat or even partially ulcerated down here. These are lesions that EMR will not get, but ESD can go into the wall. And the purpose of ESD is going to be to give our pathologist one piece, and then they can use that piece of tissue. And if there is cancer in there, they will be able to stage the cancer accurately with a T stage, and that it gives myself and oncologists more information. These are some slides that talk about how ESD is curative for early superficial esophageal adenocarcinoma and early Barrett's with high-grade dysplasia. The en-bloc resection rate was 92%, and curative rates were 74% and 65%. Here's kind of what it looks like doing an ESD. You'll find the target lesion, you mark around it, and then basically lift it up and dissect it out, put it on the wax board. Again, this lesion here, we're going to mark around it, lift it up, dissect it out, put it down, and send off to our pathologist. Briefly, ESD is better than EMR at curative resection, decreased risk of recurrence, but it takes longer, and you have to have more skill to do it. Now, lastly, patients who have, again, Barrett's esophagus with dysplasia, that was cutting it out. Now we're going to move on to burning it, and we burn it with radiofrequency ablation. Radiofrequency ablation is going to flash burn the Barrett's esophagus. It will heal over and form squamous esophageal mucosa afterwards. It's only used if it's the segment of Barrett's is not nodular. It does carry a stricture rate of about 8%. Perforation rate is extremely low, and it's pretty good at getting rid of all intestinal metaplasia at 2 years, high-grade dysplasia and low-grade dysplasia. We use a balloon for a long segment. The balloon blows up, we step on a pedal, and a flash burn to the esophagus. This is Barrett's esophagus. This is the balloon. This is what it looks like. You get this palish, kind of irritated mucosa, and then we come back a few weeks later and you don't see the dark pink intestinal metaplasia anymore. I explain to patients this is like a sunburn after they get their first treatment of RFA. You're going to feel it the night of, and by the time they get to bed, they're really going to feel it. Next day is going to be the worst, and then it starts to improve. And I send my patients home on a few days of narcotic medication and suspension of lidocaine and Mylanta. This is just the paddle form to touch up on smaller segments. The AIM trial showed that RFA decreased progression of dysplasia versus a sham, and it decreased the incidence of cancer. It's a large database shows that it's very durable. Our goals of endoscopic therapy are to get rid of Barrett's esophagus. We want to turn it back into normal esophageal tissue, and doing both ESD, EMR, and RFA, we're going to have complete eradication of dysplasia at about 90% and complete eradication of Barrett's without dysplasia at about 80%. But I do want to go through this last slide that and when I meet a patient, I'm doing Barrett's therapy, sometimes they get the idea that, oh, I'm going to see you're going to do this, and then I'm on my way and everything's cured. And the answer is absolutely not. So patients, once we have achieved complete eradication of their Barrett's esophagus, we are going to continue to do EGDs and survey them, because the recurrence is 8 to 10% per year and 2 to 3% for dysplasia. Most of it occurs near the junction of the esophagus and stomach. Most of it is visible. And so patients who have low-grade dysplasia will do an EGD every 6 months for the first year, then annually after that. we can always increase that interval to every 2 to 3 years if we don't see any recurrence. Patients with high-grade dysplasia or early cancer, the frequency of surveillance after getting rid of the Barrett's increases. And I think that's enough of that. So I'll be interested if anybody has any questions or comments.
But I'm muted. Okay, there we go.
Okay.
So there is a question in the Q&A box, and I'll ask that for you. So this will test me whether I was actually listening to you or not, because I do believe early on you answered this, and they said they couldn't join until late. So
okay.
When should we get an esophagram versus upper GI versus EGD with our GERD patients? So as I recall, in your patients, and unless there's something else going on you're concerned about, you go to EGD when you have the symptoms that are suggestive that you need further intervention other than trying a trial of medicine.
Correct. So that's a great question. And I actually do order esophagams, but the American College of Gastroenterology says you cannot diagnose reflux on esophagram alone. So if a patient has alarm symptoms, which are obstructive, they're vomiting, difficulty swallowing, painful swallowing, they've had coffee ground emesis, black tarry stools, or they're anemic, or they've had an unexplained weight loss, and bad heart, bad lungs, bad kidneys, high risk for sedation, that kind of thing. Those are patients I'll even myself order an esophagram on to look for, hey, look, there's something there, something else is going on. We need to undergo the risk of sedation, do the EGD.
So a question that I thought of during this, because everything that you were talking about with medication had to do with the minimum effective dose.
Yes.
Which makes sense. I mean, that's how we do antidepressants. It's how we do antihypertensives. Why not do that with PPIs as well? So totally get that. But what if, because as you pointed out, and it's not necessarily correct, but PPIs have been related to everything from root rot to athlete's foot, some of which is true and most of which is not. So what if the minimum effective dose is the highest available dose of the most potent PPI?
Oh, great question. That's a great question. I think, it's that seesaw of, gosh, it could lead to osteoporosis. Now, the Alzheimer's thing is out of the window, okay? Nobody's proven the Alzheimer's, but as far as kidney disease, osteoporosis, those are the two ones that we still kind of keep an eye on. I would, if it's my patient and they're over the age of 60, I actually kind of, hey, has your primary care doctor done a DEXA scan, and making sure we're doing routine labs to look at kidney function as well. So I think there has to be, in those occasions, you want to monitor them for those potential complications. Did I answer it right or not really?
Yes. No, that's
okay.
That's good, because so it's not completely taboo if the lowest effective dose happens to be the maximum dose.
Correct.
It's just like with every medicine at maximum dose, we have to be cautious of all the potential side effects and monitor for them.
Yes, and hopefully, and those are going to be traditionally, statistically, those are going to be the group of patients that are going to have hiatal hernias, anatomical problems. They're also going to have moderate to severe reflux disease seen on EGD. They're going to have that Los Angeles class C or D esophagitis. Those are going to be your traditional ones that are going to need those PPIs at the highest doses. And if they did, perhaps, hey, Dr. Evans, my patient, he's gotten a bump in his creatinine and his creatinine's going up and the nephrologist is getting worried about this PPI, then we would sit down and say, well, let's talk about surgical therapy or endoscopic therapy, to try to get them off or get those PPIs down. So those are the ones that you'll kind of, let's go maybe look at some invasive options.
My theory was always with patients that they were in that category as the known risk of Barrett's and esophageal cancer are probably worse to me than the potential risk of osteoporosis and other issues.
Exactly. And that's, yeah, you hit the nail on the head there. Because I've, and that's where the news gets a hold of this. I remember hearing about these things on the news, and they tell you, osteoporosis, Alzheimer's disease, but they don't tell you that, wait a minute, PPIs can protect you from esophageal cancer, which is way more lethal. So, but it's a balancing act. And I guess the other thing, just on a side note about PPIs, is that some patients will have side effects to one PPI, but not another. So it's okay to change. And some may even have an effect on omeprazole, but they don't have an effect on protonics. So sometimes that can be an issue. I forgot to mention that. So sometimes switching it can be helpful.
Well, thank you, Ben. I really appreciate it. It was a great presentation. I'm sure everybody learned a lot. So I appreciate everybody joining us today. You'll get an email with a link to do an evaluation so you can get CME credit, and I hope everyone has a great week.